discussion is going to be on injury, inflammation, and healing, Chapter 3. The chapter objectives are to understand the process of tissue healing from cellular level, introduce the types of agents and factors that cause and contribute to cellular injury, understand the phases of normal and abnormal tissue healing, discuss differences between acute and chronic tissue injury, and understand when it is appropriate for the PTA to begin mechanical stress stimulation in the healing process for musculoskeletal tissue. Our question for today is, which of the following best describes the role of inflammation in the healing process following soft tissue injury? A, it is a pathological process that should always be suppressed to prevent tissue damage. B, it is a necessary biological response that initiates tissue repair. C, it only occurs in response to infections, not mechanical injuries. Or D, it primarily functions to regenerate new tissue without involvement of the immune system. Pathology is defined as the structural and functional changes due to disease or trauma. And it is important and also required to understand the normal tissue function so that we can understand when there is a dysfunction. The 3 stages of pathology include cell injury, which is caused by various factors, inflammation, which is a secondary response to injury, and tissue healing, which is restoration towards homeostasis. Psychoneuroimmunology explores nervous system influence on immune and inflammatory responses. Cells like mast cells, T cells, neutrophils, and monocytes release mediators affecting tissue physiology. Aging and other factors impact healing and homeostasis. Cellular aging affects various components of the cell, including mitochondria, ribosomes, and cell membranes. DNA damage from physical, chemical, or biological factors alters function. Theories on cellular aging. Wear and tear, where organs decline due to accumulated change. Genetic hypothesis is aging is genetically predetermined. The free radical theory is DNA damage and oxidative stress contribute to aging. And the telomere aging clock. Telomeres regulate aging by limiting cell division. The discovery of telomeres, which are the structures at the end of chromosomes, has added the telomere aging clock theory for the molecular mechanisms that lead to cells and tissues growing old. Stressors like physical trauma, toxins, infections, and mechanical stressors can cause cell injury. There are 2 types of cell injury: sublethal, which is mild and reversible. The cell adapts and restores homeostasis. Then there's lethal, which is more severe and irreversible. This leads to cell death. Inflammation is important to remove harmful agents and initiate healing. The severity depends on the type and extent of injury. Regeneration is the full restoration if possible. Repair occurs when fibrosis or scar tissue is formed if regeneration isn't possible. Factors that affect healing include the tissue type, so muscle, bone, or nerve, the severity of the damage, and the overall health of the individual, including age, nutrition, or other diseases. Ischemia, which is insufficient blood flow, is caused by blocked arteries, such as in atherosclerosis and a thrombus. It causes increased tissue metabolism exceeding blood supply. The effects are hypoxia, which is partial oxygen loss, or anoxia, which is total oxygen loss. There's reduced oxygen, which leads to loss of aerobic metabolism, which leads to ATP depletion. Ion imbalances lead to cell swelling and loss of function. Infectious agents include bacteria, viruses, fungi, protozoas, and parasites. Bacteria and viruses are the main culprits. Bacteria release toxins that break down cells and tissues. Viruses hijack cells to replicate, leading to cell death. Sepsis is widespread infection and can cause organ failure and death. The immune system reactions occurred due to the immune system overreacting, causing harm. Allergies involve the release of histamine, leading to symptoms like asthma or anaphylaxis. Autoimmune diseases occur when the body attacks its own self, such as in type 1 diabetes. Also, genetic factors. Some diseases result from genetic mutations or chromosome abnormalities, such as in Down syndrome with extra chromosome 21, which leads to developmental delays. Nutritional imbalances. Deficiencies can cause diseases, such as lack of iron can cause anemia. Excessive nutrients, example obesity, can also lead to complications. Severe malnutrition is still a major global issue. Physical factors include trauma from accidents, falls, or injuries that can lead to tissue damage. Extreme temperatures can cause burns or frostbite. Radiation can harm DNA and kill healthy cells. Mechanical factors such as repetitive stress can lead to injuries like tendinitis. Prolonged poor posture can weaken tissues. And controlled stress, such as exercise, strengthens muscles and bones. Chemical factors include toxins and drugs that can damage cells. Some chemicals become harmful after metabolism, such as excessive acetaminophen can lead to liver damage. Free radicals are unstable molecules that can damage DNA, proteins, and cell membranes. Antioxidants, such as vitamin C, help neutralize these harmful effects. Also, psychosocial factors, such as stress, fear, and anxiety, can affect tissue adaptation and injury. Reversible injury occurs when the cells are stressed but can recover once the stress is removed. Ion imbalances lead to increased sodium and calcium inside the cell. Cell swelling happens due to fluid influx, especially in organelles like mitochondria and the endoplasmic reticulum. The cells use anaerobic glycolysis instead of efficient energy production, causing lactic acid buildup and acidifying the cell, which slows metabolism. The plasma membrane may form blisters and ribosomes may detach, reducing protein production. If the damage isn't too severe and the cell can restore its energy or neutralize the injury, it can recover and return to normal. When stress lasts over time, cells undergo adaptations to survive. Atrophy is cell and organ shrinkage due to lack of use, such as muscle wasting. Hypertrophy are cells and organs that enlarge due to increased demand, like the heart muscle thickening in response to high blood pressure. Hyperplasia is an increase in cell numbers, usually due to hormonal or chronic stimuli, like the uterine lining thickening with estrogen, or calluses from repeated skin pressure. Metaplasia is when one cell type changes into another to cope with stress. An example is respiratory cells in smokers change to a type that is more resistant but less functional. And dysplasia is abnormal growth and changes in cell structure, often seen in areas undergoing chronic injury or precancerous changes. Irreversible cell injury leads to cell death when the stress is too severe or prolonged for the cell to adapt. Key features of irreversible injured cells include damage to the nucleus, mitochondria, and lysosome, and rupture of the cell membrane. Pycnosis is when the nucleus shrinks and the chromatin condenses into a solid mass. Karyorrhexis is the pycnosis nucleus fragments. Karyolysis is when the nucleus dissolves. Mitochondrial changes include they lose their ability to generate ATP, causing energy failure in the cell. Swollen mitochondria may become flocculent, dendrites, or lipid protein aggregates, and calcium deposits. Lysosomal changes include the release of digestive enzymes into the cytoplasm, initiating necrosis, which is the breakdown of the cellular structures. This degradation allows for easier removal of dead tissue by phagocytes, preparing the area for either repair or regeneration. The cell components spill into the extracellular space, and these molecules can be detected in blood tests, providing clinical markers of cell injury, especially in conditions like myocardial infarction or viral hepatitis. Necrosis occurs when cells undergo irreversible injury and their contents are digested by enzymes. Different types of necrosis are categorized based on the tissue appearance and the mechanisms of cell death. Coagulative necrosis typically occurs in ischemic tissue where there's a lack of blood flow. It is characterized by cell death with preservation of tissue architecture, often seen in the heart and kidneys. Liquefactive necrosis occurs when the cells are digested by their own enzymes, leading to a liquid mass. This is common in brain tissue or in bacterial infections. It is seen in wet gangrene due to bacterial infections. Gangrene is a form of tissue death associated with bacterial infections and poor blood supply. Dry gangrene is associated with coagulative necrosis, often seen in peripheral vascular disease. Wet gangrene involves liquefactive necrosis and may produce gas bubbles due to the bacterial fermentation. Clostridial myonecrosis is considered gas gangrene and is caused by Clostridium perfringens, leading to muscle necrosis and gas formation. Tissue healing starts soon after injury and happens in two ways, both either regeneration, which is the regrowing of original tissue, or repair, which is forming a scar. The process begins with inflammatory cells from the bloodstream clearing out dead tissue using enzymes and phagocytosis. Healing is influenced by various components like fibronectin, collagen, and specialized cells, as well as factors that impact recovery. Fibronectin is a large glycoprotein that plays a crucial role in cell adhesion, migration, and differentiation. Fibronectin plays several critical roles in wound healing, particularly in scaffold formation by providing structural support that stabilizes the healing tissue, tensile strength by contributing to the strength of the healing tissue, and a gluing function, binding various substances and cells together during the healing process. Fibronectin is one of the earliest proteins to contribute to the structural support of healing tissue. Plasma proteins that leak from inflamed blood vessels are a primary source of fibronectin, which binds to fibrin, a protein that helps form blood clots, in the injured tissue. It also binds to various proteins in the extracellular matrix, stabilizing the tissue undergoing repair. Protoglycans are protein carbohydrate complexes that are secreted by fibroblasts during the initial stages of tissue repair. They bind to fibronectin and collagen, stabilizing the tissue being repaired. They also retain water, helping to hydrate the healing tissue. Once the tissue heals, protoglycans contribute to collagen organization and the stability of extracellular matrix. Elastin is a protein that provides elasticity to tissues. It is synthesized by fibroblasts and forms cross-linked fibrils, which contribute to the flexibility and resilience of tissues. Together, protoglycans and elastin contribute to hydration, stability, and elasticity of healing tissue. Collagen is the most abundant protein in the body and is crucial for providing structural support and tensile strength to nearly all tissues and organs. It is especially vital during tissue repair, where it forms the extracellular matrix of scar tissue. Type 1 collagen is the most abundant type, providing strength and stability to tissues such as tendons, bones, and scars. Type 2 collagen is found in cartilage, providing structure and support. Type 3 collagen is the first type of collagen to be deposited in wound healing. It is more flexible and less stable than type 1 collagen and is found in tissues like skin and blood vessels. Type 4 collagen forms the basement membrane, which anchors certain cells like epithelial and endothelial cells. Type 3 collagen is initially produced by fibroblasts, providing early structural support. Over time, type 1 collagen replaces type 3 collagen, enhancing tensile strength and contributing to scar formation. Components of tissue healing overview. Fibronectin is a glycoprotein that provides a scaffold for tissue repair and supporting cell migration and adhesion. Protoglycans and elastin are important for maintaining the structural integrity and elasticity of tissues as they heal. Collagen provides strength and structure during tissue repair and scar formation. Collagen fibers are laid down by fibroblasts during the repair process. Parenchymal cells are the functional cells of the organ, which may undergo regeneration to restore tissue function. And endothelial cells that line blood vessels and contribute to angiogenesis, the formation of new blood vessels, which is crucial for delivering nutrients and oxygen to the healing tissues. Growth factors are proteins produced by cells involved in tissue repair and regulate cell function like proliferation, differentiation, migration, and angiogenesis. They promote protein synthesis and degradation, integrate inflammatory responses with tissue repair. Disruptions lead to delayed healing or abnormal scars, such as an keloid or hypertrophic scar. Growth factors bind to cell receptors, triggering signaling pathways leading to protein phosphorylation and gene expression. Nutrition supports active metabolism in cells involved in tissue repair. The effects of deficiency include vitamin C deficiency, which leads to defective collagen formation, or zinc deficiency, which impairs collagen degradation and protein synthesis. Increased protein catabolism from trauma, such as surgery or infection, leads to nutrient depletion, hindering healing. Cancer patients and those on chemotherapy often face poor nutritional status, impairing healing. Other factors that influence healing include vascular supply. It is important because it carries oxygen, nutrients, and immune cells to the wound site. Infection, prolonged inflammation and tissue damage due to infection delay healing. Immunosuppression reduces the ability to fight infections, slowing healing. As we age, there's slower collagen production and cell regeneration. Comorbidities such as diabetes, heart disease, complicate healing by impairing circulation or immune function. Medications such as corticosteroids suppress inflammation, impairing tissue healing. Chemotherapy and radiation target rapidly dividing cells, including those involved in healing. And smoking reduces oxygen levels and impairs circulation, delaying healing. Chronic sympathetic nervous system activation from stress impairs immune function and tissue repair. Collagen and tissue mobilization. So collagen plays a central role in scar tissue formation during the healing process. However, scar tissue can be stiff and less flexible compared to the original tissue, leading to restrictions in range of motion and functional movement. Techniques like myofascial release or friction massage are often used to try to modify collagen alignment and increase tissue mobility. While there is ongoing debate about whether these techniques can effectively break down collagen crosslinks and realign fibers, regular mobility and stretching help to maintain flexibility, tissue flexibility, and prevent excessive cross-linking that leads to stiffness. Immobilization during the healing process can lead to the overproduction of connective tissue and a loss of tissue hydration, which increases collagen cross-linking and stiffness, reducing the tissue's extensibility. Therapeutic ultrasound is commonly used to enhance collagen tissue extensibility, reduce fibrous tissue density, and assist in scar tissue remodeling. While some benefits are documented, the exact mechanism, such as the ability to break down collagen crosslinks, are still being researched. Ultrasound can enhance the movement of molecules within tissues, increasing cell permeability, promoting protein synthesis in fibroblasts, and aiding in repair and regeneration of tissue, particularly during the proliferative phase of wound healing. Pulsed ultrasound is especially effective in the acute phase of injury to stimulate vasodilation and increase tissue oxygenation without generating significant heat. Pulsed ultrasound may provide benefits for tendon healing and collagen synthesis during early stages. As the tissue moves into subacute remodeling phase, continuous ultrasound is used to generate heat, increasing viscoelastic properties of collagen and improving tissue extensibility. This can assist in the reduction of joint adhesions and increase the flexibility of mature scar tissue and tight capsular tissue. The increased collagen extensibility that results from ultrasound is more beneficial when followed by slow static stretching. This helps to maintain the length and flexibility of the newly aligned collagen fibers. The stretch should be held until the collagen reaches its deformation phase, which is critical to prevent the collagen from reforming in its original shorter position. Ultrasound can help break down adhesions in joints, tendons, and capsular tissue, allowing for better tissue mobility and combined with stretching. Joint mobilizations and manual therapy may also be used in conjunction with ultrasound to improve range of motion and reduce restrictions caused by scar tissue. During the first few days to weeks of injury, care must be taken not to overdo ultrasound use. Pulsed ultrasound at low intensities may be more effective during this phase, as continuous ultrasound can hinder the repair process. During the subacute and remodeling phase, the fibroblastic and early remodeling phase, continuous ultrasound can help to break down the collagen matrix, facilitate collagen remodeling, and increase tissue flexibility. Careful monitoring is necessary to assess the patient's response to treatment. Pain, swelling, or decrease in range of motion can indicate that the treatment is not effective and may need to be adjusted. Combining ultrasound with other treatments such as electrical stimulation or laser therapy may not always yield superior results. However, ultrasound has been found to be effective on its own, especially when followed by stretching. Stretching and active movement after ultrasound treatment. Active motion through the full range of motion is critical to further enhance the tissue mobility. The PTA should emphasize the importance of continuing activity and not just rely on ultrasound alone. Acute wounds caused by trauma or surgery usually heal according to the well-defined process with the following 4 phases that overlap and can take months to years to complete: hemostasis and degeneration, inflammation, including acute and chronic inflammation, and proliferation, migration, and remodeling and maturation. Hemostasis is the first step of healing. It occurs right after tissue injury to stop bleeding. First, there is a coagulative cascade. Blood fills the injury gap. Platelets clump together to form a loose clot. Platelets release chemical messengers, including growth factors. Growth factors stimulate inflammatory cells such as neutrophils and macrophages to the site. Growth factors promote epithelial cells, fibroblasts, and endothelial cell migration and proliferation. They also regulate cell differentiation and extracellular matrix protein expression. Inflammation and degeneration phase is characterized by the formation of a hematoma, which is a blood clot. necrosis of dead cells, and an inflammatory response, which includes fluid influx to dilute harmful substances and support infection-fighting cells. Inflammatory cells, neutrophils, and macrophages remove dead tissue. The degeneration phase involves tissue breakdown and removal of dead cells and prepares the site for the next phase of healing. Inflammation is essential for healing and protective and curative features. The goal is to replace injured tissue with healthy tissue or scar tissue, and it begins after the blood clot formation. Some of the key features include vasodilation and increased capillary permeability. This allows immune cells to move to the injury site. The immune cells destroy bacteria, release protease, and secrete growth factors. Growth factors, cytokines, and chemokines are bioregulators of the inflammatory phase. Granulation tissue formation begins around 5 days post-injury, where fibroblasts, epithelial cells, and endothelial cells form weak granulation tissue, increasing the risk of wound reopening. The basement membranes support cells, regulate cell attachment, migration, and differentiation. They are found in tissues like the kidney, placenta, and nervous system. Inflammation is generally beneficial, but it can be harmful if prolonged or severe, causing damage to healthy tissue. Some of the clinical manifestations of acute inflammation include redness due to arterial constriction and vasodilation, swelling caused by exudation of cells and leukocyte infiltration, heat from vasodilation, pain from increased pressure from edema on nerves, and decreased function due to loss of movement or function at the site. The acute inflammation process includes inflammatory stimulus, which affects blood vessels and plasma, and chemical mediators that alter vascular tone, increase permeability, and cause accumulation of plasma proteins, fluid, and blood cells at the injury site. There can also be increased muscle tone and spasms, loss of motion and function, and passive movement testing may show a spasm end field or pain before resistance. The outcomes of acute inflammation include complete resolution, which is restoration of normal tissue structure after a mild trauma, healing with scar formation after significant tissue destruction or prolonged edema, and chronic fibrosis, which occurs after prolonged inflammation leading to tissue changes. Acute inflammation subsides once the injurious agent is removed. Chronic inflammation occurs if there is extensive necrosis, inability to regenerate parenchymal cells, such as in the heart or central nervous system, or if the underlying cause persists. Causes of chronic inflammation include failure to address the underlying cause, repeated episodes of acute inflammation, or low-grade persistent immune reactions. Key features include accumulation of macrophages, lymphocytes, and plasma cells. The macrophage accumulation is the result of chemotaxis, which is the movement of an organism or entity in response to a chemical stimulus, of monocytes, which are precursors to macrophages, to the injury area of injury. Macrophages modulate lymphocyte function, promote endothelial cell and fibroblast growth. Granulation tissue is formed by proliferating endothelial cells and fibroblasts. It is seen in healing open wounds and appears as a red, beefy tissue with pinpoint red dots, which are new capillaries, and a granular surface, which is new collagen. Healing with chronic inflammation leads to incomplete return of full function. Some of the key processes include vascular repair, where endothelial cells restore blood supply, matrix repair, where fibroblasts produce collagen and protoglycans to form extracellular matrix, and scar formation, where granulation tissue matures into connective tissue scar. This is regulated by growth factors released by macrophages, platelets, and plasma cells. Vascular alterations occur from minutes to a few days after the injury. It is triggered by the injury with or without vessel wall disruption. Some of the key vascular events include vasoconstriction, which happens initially, which slows the blood flow to minimize blood loss. Platelet aggregation forms the blood clot to reduce bleeding. Vasodilation becomes sustained, where it increases blood flow, which causes redness or arrhythmia, and warmth, and increased hydrostatic pressure, which leads to fluid leakage into tissues, causing swelling. Some of the key steps in leukocyte recruitment include stasis, where exudation, which is the process of the oozing or leaking out of fluid that is released, of fluid and proteins, which leads to vessel engorgement, which leads to blood flow slowing down or stopping. Margination is where leukocytes accumulate along the vessel walls and adhere to endothelial cells. It is mediated by adhesion molecules acting as receptors and counter receptors. Diapedesis, where leukocytes squeeze through the vessel walls into the interstitial tissue without damaging vessels. And chemotaxis, where leukocytes migrate to the injury site guided by chemical gradient of attractants. Here we'll discuss the different leukocyte types and their functions. So neutrophils are present during acute inflammation or a bacteria. They are first responders and are short-lived, about 24 hours. They release lactoferrin, which binds iron to inhibit bacterial growth, and defensins, which are antibiotic peptides. Monocytes and macrophages are involved in chronic inflammation and cleanup. They replace neutrophils, clean up debris, release growth factors for tissue repair. Lymphocytes are involved in viral infections and tumors. They fight viruses, tumors, and long-term immune response. Eosinophils are involved in allergic responses and parasites. Inflammatory exudates. So you have hemorrhagic sanguineous, which is bright red or bloody with the presence of red blood cells. Small amounts are expected after surgery or trauma. Large amounts may indicate hemorrhage. Sudden large amounts of dark, red, bloody may indicate a draining hematoma. Serosaginous is blood-tinged yellow or pink with the presence of red blood cells as well. It is expected for 48 to 72 hours after injury or trauma to the microvasculature. A sudden increase may precede wound dehiscence, which is the rupture or separation of a wound. Serous is a thin, clear yellow or straw colored and contains albumin and immunoglobulins. This occurs in early stages of most inflammations, common with blisters, joint effusion, and rheumatoid arthritis. Viral infections is expected for up to 1 week after trauma or injury. A sudden increase may indicate a draining serum, which is a seroma, which is a pocket of serum within tissue or organ. Purulent is viscous, cloudy, and pus-filled. Cellular debris from necrotic cells and dying neutrophils. Usually caused by pus-forming bacteria such as streptococci or staphylococci, and indicates infection. It may drain suddenly from an abscess or a boil. Catarrhal is thin, clear mucus seen with inflammatory process within mucous membranes such as upper respiratory infection. Fibrinous is thin, usually clear, maybe yellow or pink, tinged, or cloudy. It occurs in severe inflammation or bacterial infections and does not resolve easily. It can cause fibrous scarring and restriction. Within 2 days post-injury, endothelial cells from nearby viable blood vessels begin to proliferate, aiming to reestablish a vascular network for transporting oxygen and nutrients to support tissue metabolism during healing. These endothelial cells bud out from the existing blood vessels and form new capillary channels, which gradually merge and grow toward the tissue defect caused by the injury. This process is known as neovascularization or angiogenesis. The newly formed blood vessels and connective tissue matrix create a rich vascularized tissue visible in healing wounds, often referred to as granulation tissue. Granulation tissue is historically composed of endothelial cells, fibroblasts, and inflammatory cells. Initially, the new blood vessels are leaky, contributing to edematous or swollen appearance of the healing tissue. As healing progresses, blood flow through the newly formed vasculature decreases, and the non-functional vessels are gradually degraded, leaving behind a few vessels in the mature scar tissue. During the proliferation phase, there is a decrease in the inflammatory cells and fibroblasts. Endothelial cells and keratinocytes take over the synthesis of growth factor, which further promotes cell migration and proliferation. The synthesis of extracellular matrix components continues facilitating the formation of new capillaries and tissue regeneration. As the wound heals, the damaged matrix needs to be removed before the newly synthesized components can be integrated properly. Protease is secreted by neutrophils, macrophages, fibroblasts, epithelial cells, and endothelial cells, and play a role in breaking down the damaged matrix. Fibroblasts are drawn into the provisional matrix, which is composed of fibrin and fibronectin, and start synthesizing collagen, elastin, and protoglycans. This cross-linking of collagen contributes to the formation of the initial scar. Epithelial cells from the wound edges migrate across the highly vascularized extracellular matrix, forming the granulation tissue and ultimately reforming the epidermal layer. This process of epithelialization can take several weeks depending on the size and depth of the wound. In the maturation phase of healing, the scar tissue undergoes remodeling to become smoother, stronger, less dense, and less red. The number of blood vessels in the area decrease, which contributes to the fading of the red appearance of the scar. Fibroblasts and capillary density, which are critical in the early phases of healing, declines as the tissue matures. This process occurs mainly through apoptosis, which is programmed cell death. The remodeling phase can last for years as collagen fibers are continuously broken down and rearranged to withstand stress. Over time, scar tissue becomes stronger and more relaxed and lighter in color. As healing progresses, the extracellular matrix draws together, causing contraction of tissue, which helps to reduce the size of the tissue defect caused by the injury. Some fibroblasts in the healing tissue differentiate into myofibroblasts, which contain contractile proteins and contribute to tissue shrinkage. Tissue contraction is a normal part of healing and helps close wounds, but excessive contraction can lead to contracture, a condition where tissue shrinks excessively, potentially impairing function and causing disfigurement. Contractures are often seen in cases like severe burns, where hypertrophic scarring can limit movement and cause disability. Arthropfibrosis, or joint contracture with fibrotic tissue buildup, can occur post-surgery or injury, especially in joints like the shoulder and knee. It is often caused by factors like prolonged immobilization, infection, or improper grafting positioning after ligament reconstruction. After a lethal injury to skin, epithelial cells surrounding the necrotic tissue detach and migrate into the damaged area, replacing dead cells. This process is known as regeneration, which restores normal tissue structure and function. Regeneration can only occur in tissues like epithelial cells, where the cells can undergo mitosis. Permanent tissue like cardiac monocytes and neurons cannot regenerate because they cannot divide. Regeneration is ideal for restoring function, as seen in superficial wounds like skin abrasions, where the epidermis regenerates with minimal scarring. In stable tissues like liver and skeletal muscle and kidneys, cells can be induced to regenerate under the right circumstances. Neurogenesis, which is neuron regeneration, is limited to specific regions of the brain, such as the hippocampus and olfactory bulb. This process may increase in response to brain injury or disease contributing to tissue repair. Tissue repair in skin typically involves both regeneration of epithelial cells and scarring, which is the formation of the connective tissue. Scarring occurs when tissue damage extends beneath the epidermis and connective tissue is required to fill the gap. Minimizing scarring is crucial not only for cosmetic reasons, but also to preserve function. Excessive scarring can interfere with organ or joint function, as seen in cases like keloids or hypertrophic scars. Primary union, or healing by first intention, occurs when wounds are closed with minimal scarring, typically in clean, small wounds. In larger wounds or those with infection, secondary union occurs, leading to more scarring and a longer healing process. Even after the wound closes, collagen remodeling continues, strengthening the scar tissue over time. However, the healed tissue is never as strong as the original tissue and is typically about 20 to 30% weaker than the normal skin after complete maturation. In some individuals, particularly of African or Asian descent, there's a genetic predisposition to produce excessive collagen during healing, leading to the formation of keloids, which grow beyond the original wound boundary and invade surrounding tissue. Some organs have cells that cannot regenerate, such as the heart and central nervous system cells. Organs like the liver and epithelial cells regenerate through mitosis. Skeletal muscle cells and renal cells can be induced to undergo mitosis, but don't typically divide. Factors that affect regeneration include the cell type, cell's ability to divide, the type of damage, and other factors such as nutrition, age, immunocompetency, vascular supply, and the presence of infection. Essential for regeneration is parenchymal cells. Chronic inflammation may occur when regeneration is not possible, impairing healing. Lung tissue repair. Regeneration is possible if the basement membrane remains intact. Phagocytic removal of necrotic cells allows lining epithelial cells to migrate into the basement membrane and differentiate into type 2 pneumocytes. Some type 2 pneumocytes differentiate into type 1 pneumocytes for gas exchange. If the basement membrane is disrupted, healing occurs through fibrosis and scar tissue formation, potentially leading to restrictive lung disease. In the digestive tract, The gut villi is responsible for nutrient absorption and enzyme production. Healthy gut cells regenerate by growing upward from the base villi, shedding and renewing every 5 days. Complete turnover of the gut cells occurs in 3 to 4 weeks. Mildly to moderately impaired gut healing takes 3 to 6 months. More severe injury requires 12 to 18 months. 2/3 of immune system and 90% of serotonin function are in the gut. Healing the gut helps restore immune balance and serotonin levels. Proper serotonin levels are essential for melatonin production and mood stabilization. Severed peripheral nerves undergo myelin degeneration and axonal fragmentation, also known as Wallerian degeneration. Lipid debris is cleared by macrophages. Within 24 hours, new axonal sprouts emerge from the central stump. Schwann cells from both central and peripheral stumps proliferate to assist regeneration. Microsurgical approximation of the nerve can enable reinnervation. Successful regeneration requires maintenance of neurotubules to guide the new axons. Skeletal muscle is made of contractile, actin and myosin, and connective tissue elements. Sarcomere units and muscle fibers. Each myofiber is surrounded by an endomysium and arranged in bundles, and also contains satellite cells surrounding fibers, crucial for tissue regeneration post-injury. Common muscle injuries include contusion, strains, and lacerations. Contusions are caused by sudden compression force, like a direct blow. Strains, which occur from excessive tensile forces during eccentric contraction, especially in muscles crossing two joints like the hamstring and gastrocnemius. Common site of strain is at the myotendinous junction where the muscle fibers meet tendons. The myotendinous junction is vulnerable due to transition between compliant muscle fibers and non-compliant tendons. Muscle tissue can regenerate but depends on injury type. After severe injury or infection, muscle fibers may be extensively destroyed, but sarcolemma sheaths usually remain intact. Regeneration occurs via mitotic division of satellite cells, forming myoblasts for new fiber growth. In severe injuries, connective tissue matrix may disrupt satellite cell activity, leading to scar tissue formation instead of regeneration. Scar tissue reduces muscle's ability to withstand tensile forces, increasing risk of injury. Muscle healing phases include hemostasis with hematoma formation and inflammation during that first 24 to 48 hours. Phagocytosis with the removal of debris, which is activated by satellite cells. Myofiber regeneration and occurs around 6 to 8 weeks. And tissue remodeling, where full reorganization and maturation of muscle tissue occurs. Sarcopenia is muscle mass loss of about 1% per year after the age of 30. By the age of 40, muscle elasticity decreases and fibrinogen leaks from vasculature into intracellular spaces, causing microfibrinous adhesions that contribute to stiffness. Age-related changes in collagen and reduced water content in tendons and ligaments also contribute to stiffness. Chronic pain leads to changes in motor control and motor recruitment strategies. These include feed-forward mechanism, cortical plasticity, and task specificity. Motor inhibition is the decreased activation in muscles on electromyogram, even when muscles should be active. Task-specific inhibition is where muscle recruitment patterns are normal in one motion but absent in another. Global inhibition is where muscle inactivity in most motions or tasks, signaling need for different interventions. Treatment for pain management and muscle strengthening should focus on restoring normal motor recruitment patterns. As a review, the types of bone tissue include cortical bone, which is dense, tough outer layer and composes about 80% of the bone, and cancellous or trabecular bone, which is the spongy bone and accounts for about 20% of bone, intermeshing thin plates of trabeculae in contact with bone marrow. The two surfaces include periosteal or the external surface and endosteal, which is the internal. Bone loss occurs when there is an imbalance between bone resorption, which is osteoclast activity, and bone formation, which is osteoblast failure, and can result in defective mineralization of bone matrix. Conditions affecting bone include fractures, infections, inflammation, metabolic disturbances, tumors, prosthesis response, bone infarction, and systemic diseases with skeletal manifestations. The process of fracture healing includes hematoma formation. So immediately after the fracture, blood vessels are torn, causing a hematoma at the fracture site. Hematoma delivers fibroblasts, platelets, and osteoprogenitor cells, promoting the transformation of the hematoma into granulation tissue, which leads to a callus formation. The inflammatory phase, which begins a few days after the injury, is where inflammatory cells and vascular response lead to pain, swelling, and heat at the injury site. Fibrin meshwork forms, providing a scaffold for fibroblast and capillary ingrowth. By the end of the first week, phagocytic cells remove hematoma and neovascularization begins. The reparative phase, which occurs between weeks 2 and 12, is the formation of a soft callus, which is visible in radiographs around 2 weeks. Osteoclasts clear necrotic bone, periosteum and endosteum regenerate. The soft callus is replaced by a hard callus, and endochondral ossification occurs. Bone growth factors also play a major role. The remodeling phase, which lasts months to years, is where the bone returns to normal surface and function. The immature woven bone is replaced with mature lamellar bone, which provides stability to the fracture. Excess bony callus is resorbed, and the bone remodels based on mechanical stresses. So bone remodeling in normal adult skeleton, about 10 to 30% of the bone is replaced or remodeled to replace microfractures and maintain mineral balance. The bone cells involved include osteoblasts, which produce bone matrix and mineralization, osteoclasts, which resorb bone, osteocytes, which detect mechanical loading and signal osteoblasts to initiate remodeling. This is why it is important during bone healing that there is mechanical stresses being placed on that bone to help with the bone remodeling. Bone healing time varies depending on bone type, fracture site, the treatment required, the soft tissue injury, and other factors such as age, vascular supply, nutrition, and immunity. Tendons and ligaments have viscoelastic properties, allowing deformation under force but return to original state after force is removed. Tendons and ligaments are made of parallel fibers of type 1 collagen produced by fibroblasts and fibrocytes. Mechanical properties depend on collagen architecture and elastic content. Tendon injury risk factors include a rapid oblique force, which can increase the risk of tendon rupture. Degenerative changes reduce tensile strength and increase rupture risk. The healing process includes hemostasis, where platelets initiate clot formation to reduce hemorrhage. The inflammatory phase during the first 72 hours to 5 days, where phagocytic cells clear debris, inflammatory cells migrate. Then the proliferation phase around 2 to 3 weeks post-injury, where granulation tissue forms with fibroblasts migration and vascular buds. Type 3 collagen secretion leads to new extracellular matrix formation. And the maturation phase from about week 3, where type 3 collagen is replaced by type 1 collagen, aligned along tensile forces. Collagen continues to remodel, improving strength and function. Full recovery may take 12 to 16 weeks. Challenges include collagen maturation, where immature collagen lacks strength and is randomly oriented. Tendon repair tissue remains weaker than healthy tendon for several months. Maximal muscle contraction should be avoided for at least 8 weeks. The long-term healing of tendons. The tendon strength may be 50% of original strength 24 weeks post-repair, and normal strength may take 40 to 50 weeks. Although tendon healing is a regenerative process, scar tissue is weaker and larger, compromising biomechanical integrity and increasing the risk of re-injury and osteoarthritis. Ligament injury is generally caused by abnormal or excessive joint motion, leading to sprains. Common sites include the ankle, knee, and fingers. Clinical signs include pain, edema, hypermobility, and loss of function. Intra-articular versus extra-articular ligaments. Extra-articular ligaments, such as the MCL, heal similarly to tendon injuries through overlapping phases of hemostasis, inflammation, proliferation, and remodeling. Intra-articular ligaments, such as the ACL, have a poor healing response due to disruption of the synovial sheath and lack of hematoma formation. Some of the healing impairments in ligaments include after injury, ACL releases large amounts of matrix metalloproteinase, also known as MMPs, which disrupt extracellular matrix turnover and hinder healing. MMP activity is less in the MCL, potentially explaining better healing outcomes compared to the ACL. Below is a list of the grades of injuries occurring to ligament tissue and is graded by severity. A grade 1 is a microscopic tearing of the ligament without producing joint laxity. Grade 2 is tearing of some ligament fibers with moderate laxity. And a grade 3 is a complete rupture of the ligament with profound instability and laxity. Next, we're going to discuss cartilage healing. The different types of cartilage include articular cartilage found at the ends of bones, made of hyaline cartilage. It is aneural, avascular, and alymphatic, meaning it lacks nerves, blood vessels, and lymphatic supply. It is composed mostly of water and type 2 collagen. This cartilage does not regenerate well, especially after adolescence, due to its low cell to matrix ratio and lack of vascular supply. Fibrocartilage is found in structures like the meniscus of the knee, the annulus fibrosus, and tendon and ligament insertions into bone. Elastic cartilage can be found in structures like the ligamentum flavum, external ear, and epiglottis. Cartilage provides compression strength due to the protoglycans, which bind water to regulate matrix hydration and play a critical role in reducing stress and providing smooth joint movement. Ideal conditions for cartilage healing. A source of cells, matrix provision, removal of stress, and an intact subchondral bone plate are essential for optimal healing. Challenges include the healing of articular cartilage is impaired due to the lack of vascularization. This lack of blood flow prevents migration of repair cells to injury site. Without intervention, articular cartilage healing may occur with fibrosis scar tissue, which does not function as effectively as healing cartilage and can contribute to degenerative arthritis. The meniscus in the knee are fibrocartilaginous structures primarily made of collagen with some protoglycan. Collagen fibers are mainly arranged circumferentially to help disperse compressive load, resist shear forces, and aid in shock absorption, and withstand circumferential tension. The vascular supply of the meniscus decreases with age. At birth, the meniscus is fully vascularized, but by adulthood, only the outer 10% to 30% remains vascularized. The blood supply comes from the perimeniscal capillary plexus. Water makes up 70% of the meniscus, providing lubrication and compressive load resistance. Collagen accounts for 60 to 70% of the dry weight, primarily type 1 collagen. Meniscal tears heal through the migration of cells from the synovial membrane, but healing is limited by vascular supply. Tears in avascular regions heal more slowly and with less efficiency. The healing process is not fully understood, but the location and type of tear significantly impact the healing ability. Clinical symptoms include pain, swelling, locking or catching, and reduced range of motion, often requiring surgical interventions. The synovial membrane lines the inner surface of the joint capsule and other intra-articular surfaces, except the articular cartilage and the meniscus. Its functions include secretion of synovial fluid, phagocytosis, and regulation of solutes. Injury to the synovial membrane involves So any injury to the joint structure can affect the synovial membrane, leading to hemorrhage, which is excessive bleeding, hypertrophy or thickening of the synovial lining, hyperplasia, which is an increase in cell number of the synoviocytes, and mild chronic inflammation. Chronic synovitis. In cases like hemophilia, where there is prolonged chronic synovitis, the following changes can occur: abnormal synovial fluid production, joint immobilization leading to fibrous adhesions, and progressive joint destruction. The impact of immobilization. Contraction of the joint capsule occurs, leading to decreased range of motion. The loss of glycosaminoglycans and associated water loss further increase capsular stiffness, which hinders normal movement. And synovial membrane hypertrophy can lead to adhesions forming between the synovial membrane and the articular cartilage. The intervertebral disc is a fibrocartilaginous structure located between the vertebrae. It is composed of three main zones: the outer annulus fibrosus, which is primarily type 1 collagen arranged obliquely. Inner annulus fibrosis. This area is a fibrocartilaginous primarily composed of type 2 collagen fibers, and the nucleus pulposus, which is the central core, which contains type 2 collagen and protoglycans. It has high water content and behaves biomechanically as a fluid cushion that transmits forces to the annulus fibrosus and vertebral end plates. The nucleus pulposus acts as a cushion that absorbs shock and distributes pressure across the disc. The high water content allows it to function as that fluid cushion. The annulus fibrosus surrounds the nucleus and is arranged in multiple concentric layers, allowing it to resist tensile, radial, and torsional forces. The disc itself is largely avascular. Nutrition is provided through diffusion and convection from the surrounding tissues, especially the vertebral end plates. While the nucleus has no nerve supply, the outer third of the annulus fibrosus is innervated, which can be a source of pain, especially in cases of chronic low back pain. Cell deterioration and degeneration. So as individuals age, cells deteriorate in the disc and contribute to degenerative changes. This is particularly noted in the nucleus pulposus and is associated with herniated disc. The predictable pattern of degeneration. The nucleus pulposus loses its ability to absorb water due to decreased cell density and reduced synthesis of type 2 collagen. As the protoglycan content decreases, the disc dehydrates and the nucleus becomes more fibrous. Fissures or tears can form in the annulus due to chronic stress and strain. Decreased shock absorption happens as the nucleus becomes less hydrated and is less able to absorb shock, leading to strain on the spine and surrounding structures. Factors contributing to degeneration include decreased extracellular matrix integrity and changes in collagen fibers that reduce the disc's load-bearing capacity. Calcification of vertebral end plates and changes in permeability can further hinder nutrient and waste exchange. Inactivity, weight gain, poor posture, and muscle weakness can slow disc healing and accelerate degeneration. Immobilization can cause significant tissue changes such as muscle weakness and loss of joint motion. PTAs should design rehab programs to address these issues. A deep vein thrombosis, or DVT. PTAs need to monitor for DVT, which is a potential complication of immobilization. Symptoms include severe pain, edema, fever, and malaise. Immobility can lead to changes in cartilage structure, including loss of the glycosaminoglycans and water, resulting in cartilage deterioration and potential osteoarthritis. Back to our question, which of the following best describes the role of inflammation in the healing process following soft tissue injury? The answer is B. It is a necessary biological response that initiates tissue repair. Inflammation is the first phase of healing, occurring immediately after injury to remove debris, prevent infection, and initiate tissue repair. It involves the activation of immune cells, release of cytokines, and increased vascular permeability. While chronic inflammation can be detrimental, acute inflammation is crucial for proper healing. If you like this video, please make sure to like and subscribe.